Okay, we're live. Hello, Dr. John Mew, Dr. Mike Mew. Please introduce yourselves for the parents watching, and we'll get into the questions. Oh, er,
Well, I'm John Mew, Professor of Orthodontics. I developed the system about 40 years ago. It is a philosophy to correct the growth of the face, and we use appliances which are called the BioBlock system.
I'm his son, Michael Mew. I had the treatment when I was younger. I've since become an orthodontist, and it's my ambition to take the system and propagate it further to improve the health of the masses.
okay. Just to let the parents know, today we are April 16th, and it's about 6 a.m. here in Vancouver, around 2 p.m. for you guys in London. Thanks for joining us. First question is, tell us about the headgear effect and a retruded maxilla, and how it's caused and how it impacts the airway.
I'll start then. The headgear effect is referred to when the upper jaw is moved back, and this will be caused by a number of things, primarily by headgear, which is deliberately intended to pull the top teeth back to match the position of the bottom teeth. But it can also apply in the same way if you use functional or fixed appliances which have what is called intermaxillary elastics, because one pulls the top jaw back in order to pull the bottom jaw forward, but the overall effect is to distalize or move back the upper jaw.
I think it would be fair to say that one of the most consistent findings in all orthodontic studies is this increase in length of the face, which is a reflection of the headgear effect. One of the big problems that I see is that the analysis of facial shapes, so the X-ray analysis, the X-ray norms that were taken by the orthodontic profession were done in the middle of the 1900s. Now, if we see malocclusion as a disease of the modern environment, it was quite a late symptom of the underlying change in facial shape. And to take these reference points in the middle of the last century is it gives you a wrong foundation stone. It's you've given a you've looked at the very tail stage of a disease and decided that the people at that point that didn't actively show the one of the symptoms, which is malocclusion, must be fine. And that's a great assumption to have been made, and it's placed one of the foundation stones in the wrong places. And a lot of orthodontists actually desire to increase the length of the face, when for us that is the underlying problem. So a lot of orthodontics is worsening the underlying problem, the length of the face, the distalization, the downward, the backward growth of the maxilla, while straightening the symptom, which is the crooked teeth. Which this is a classic example of medicine that has lost its way a little bit.
So, what happens to a person's airway and their breathing patterns and their sleeping patterns when the maxilla is pushed too far back than genetically intended?
If the upper jaw grows down or back, it tends to push the lower jaw down. The tongue is, of course, attached to the lower jaw, and as the jaw goes down, it also hinges back, and this obstructs to a greater or lesser extent the airway, so that people who have any form of retractive treatment tend to have a restricted airway as a result.
And it's important to point out here that modern society is causing many of these problems. So, we're eating softer food. I estimate that we're using our jaw muscles in modern society about 3 to 5% of the masticatory effort we did in the past. But also, we're getting nasal obstructions, our tongue's dropping down, we're changing our oral posture, first through necessity, and then it becomes habit. But also, we're in this modern environment where, we used to look to the horizon for predators or prey. We went looking to television, then desktops and laptops. yourself better when it's making the underlying condition worse. That's my concern.
Okay, okay. John, when did you first observe the headgear effect, and what made you develop the bioblock?
I can go back to the days when I was a student, which was back in the 50s, and I observed then that many people who had had orthodontics had flat faces. Just below the eye, it looks just flat, and you'll find that as a result, the nose looks prominent. And you can actually say this about 90% of the population. Very few people don't have a slightly large nose, although in fact the nose is the normal size, the maxilla is back. That, of course, restricts room for the teeth, as well as affecting the sleep apnea and joint problems, and above all, ear, nose, and throat problems, all of which stem from the same cause.
Okay. So, if an orthodontist looks at a kid with crowding in the upper jaw, and that kid also has a retruded lower jaw, how do they say that the upper jaw is then overgrown? Because if it's overgrown, wouldn't there be huge gaps in this space between the teeth?
Also comes back to me talking about these X-rays. I mean, it looks very professional to take an X-ray and hold an X-ray up to the light and make measurements on this X-ray, and it gives this sense of kudos, a sense of we know what we're doing, but it's hopelessly inaccurate to start with. The scientific validity of these X-rays really is not good, and I think it's gone beyond that. I think that they're misleading. So you've got an orthodontist here who's basing his analysis on misleading figures. So he's misleadingly thinking that top jaw is too far up and forwards. He's then going to try and pull that top jaw back to match that bottom jaw. Remember, it's incidentally a lot easier to do treatment like that. It's far easier to make the face drop down and back than it is to make the face grow up and forwards. And if your objective is to do quick, easy treatment, get nice straight teeth and churn patients out, well, it's easier to lengthen faces.
Okay. Okay, I'm going to press pause just for a sec here.